Today, we are going to be talking about the UNC 12 probe. This instrument is used to measure probing depths. We measure from the gingival margin to the attached periodontal tissue, also known as the base of the sulcus or the junctional epithelium. We can also use the probe to record signs of inflammation, such as bleeding, and to measure clinical assessment findings, such as recession, lesions, or mobility. We wouldn't want to use this instrument in cases where a tooth is in distress, such as an abscess or a recent surgery site. When we look at the probe, we see that there are markings at each millimeter with colored bands between 4 to 5 millimeter and 9 to 10 millimeter. These markings help get accurate readings. When holding this instrument, you want to have a light, modified pen grasp with a C shape. So using your thumb and pointer finger on the handle, the middle finger goes on the shank, the ring finger is your fulcrum, and the pinky stays stacked to the fulcrum. When working with this instrument, we have a correct working order. We work from tooth number 1 to 16 buccal, 16 to 1 lingual, 32 to 17 buccal, and 17 to 32 lingual. For demonstration purposes, I'm going to begin probing on tooth number 32. To begin, you want to start at the distal line angle. With a walking stroke, we will walk distal to the interproximal surface until it reaches the contact area of the adjacent tooth. We want to keep the probe in contact with the tooth surface, parallel to the long axis of the tooth. The probe should be angled towards the apex of the tooth. As we walk the probe, we look to see the tissue blanch at the junctional epithelium. Once we become interproximal, we tilt the probe 10 to 15 degrees to measure the distance into the coal space. We want to be accurate in walking the probe completely around each tooth. Each tooth is going to have 6 readings, with the deepest reading being recorded. Practicing this technique on a typodont or a classmate can promote humanism by reflecting on the application of probing and receiving constructive feedback from your partner. Use the practical exercises in the clinic and the encouraging words from the professors to foster an even deeper grasp of the learning process. When paired with a competency, constructivism and behaviorism will prove to be beneficial. After we have recorded the probing depths of each tooth, we then record the gingival margin, which is where the gingiva lies to the cemento-enamel junction. With this, we can calculate the clinical attachment loss, which is the distance between the CEJ and the JE. We either add or subtract these 2 readings. If there is recession, we add the probing depth and the gingival margin. If the gingival margin is coronal to the CEJ, we subtract. In health, the clinical attachment loss is 0. In disease, the junctional epithelium has migrated apically. Generally, healthy gums have readings of 1 to 3 millimeters in depth. A reading of 4 millimeters is generally the dividing line between a healthy sulcus and periodontal pocket.